Well, welcome. I'm honored to have the opportunity to speak to you today about a topic near and dear to my heart. That is one of the chief parasomnias, REM sleep behavior disorder. I will also give you a little bit of background on methodology for measurement of REM sleep without atonia, its polysomnographic signature. And we'll discuss this from the angle of the current understanding of REM sleep behavior disorder from a neurologist standpoint, which is that this represents in most older adults a prodromal neurodegenerative disease, what we call the synucleiopathies, chiefly Lewy body diseases, which include Parkinson's disease, dementia with Lewy bodies, or a condition called multiple system atrophy. And that's where these patients may sadly end up over the trajectory of their illness over many, many years. But it presents often to sleep clinicians, so it's important to recognize this. And we'll go through it from both that standpoint as well as the spectrum of some other causes. That's the beyond synucleinopathy part, where we'll give you some considerations in younger adults, what to think about when you see a case of REM sleep behavior disorder or even REM sleep without atonia on the polysomnogram. These are my disclosures. I don't have any consultancies or industry work, and all treatments for REM sleep behavior disorder are off-label, so anything discussed in that space is, strictly speaking, an off-label use. My sources of research support include Mayo, the Fox Foundation, Synovian, and NIH. So by way of overview then, we'll start with the idea of how REM sleep behavior disorder may typically present to the sleep clinician. And we'll see evidence that in most cases, this will end up being at some form an overt synucleinopathy. So conceptually, this represents the very beginnings of a neurodegenerative process downstream. We'll talk a bit about the differential diagnosis of other nocturnal events that can present like REM sleep behavior disorder for you to consider. And then we'll cover the beyond synucleinopathy part, which pertains moreover to younger adults. Arbitrarily, we could say those younger than 50, 55, or 60. It's worthwhile thinking of these other causes because many times the prognosis and treatment are going to be different. Last, we'll offer what little wisdom may be possible about symptomatic treatment of REM sleep behavior disorder and allude to the hope that eventually, because in most older adults this is a prodromal neurodegenerative disease, eventually we're hoping that we may have neuroprotective therapy to ward off the development of these more devastating future syndromes. So the learning objectives for this morning are to help you understand the current evidence for RBD and RISWA, as I'll call it, REM sleep without atonia on the polysomnogram as likely prodromal synucleinopathy neurodegenerative states. We'll delineate the terminology here is evolving, by the way. Idiopathic or isolated is a synonymous term for reasons we'll discuss, but we'll delineate idiopathic and isolated RBD as well as symptomatic causes for that and its neurophysiologic signature RISWA, and discuss causes and associations through the lifespan, which may in younger adults, children and adolescents include antidepressant use, autoimmunity, narcolepsy, and lesional pathology, usually in the brainstem. Then we'll discuss some of the clinical scoring methods for REM sleep without atonia on the polysomnogram so that you can appreciate in particular research applications for quantitative analysis of RISWA. So REM sleep behavior disorder is a condition of complex vocal or motor behavior during sleep. It is potentially injurious dream enactment. By dream enactment, we mean typically the complex vocalization or motor behavior will mirror what the dreamer is dreaming. Now, you don't always hear the history of dream enactment per se because sometimes the sleeper is not aware of their dreams or doesn't remember them. But if you hear that collateral history from a bed partner of likely dream enactment, often violent, most often, with punching, kicking, arm flailing, screaming or shouting during sleep, you should think of REM sleep behavior disorder as being a top possibility. Its neurophysiologic signature on the polysomnogram is REM sleep atonia loss or REM sleep without atonia. And it has a very strong association with synucleiopathy, both concurrently in some cases when it develops after a clear diagnosis of Parkinson's disease, dementia with Lewy bodies, or others, or more commonly when it presents as an initial condition. There's a hazard ratio of about 2 for development of a neurodegenerative disease in the future. Let's start with a typical case that really tells the whole story of a typical older RBD patient. This is a real-life case of a 77-year-old retired physician from a town slightly north of here in Minnesota. He dreamt he was catching a punt in American football. So he dove out of bed, trying to go after that punt in his dream, but in real life, he struck his head on the floor, which was a hardwood floor, unfortunately for him. And in the ensuing week, you can see the CAT scan, and particularly for neurologists, you'll recognize that layering over the frontal lobes here, we see subdural blood, and he had large subdural hematomas that required surgical evacuation. So a fairly dramatic presentation. 5 years later, the patient was in a nursing home, sadly, had developed dementia. So here we hear the whole story from presentation of a patient with vivid, violent dream enactment injury from the disorder who evolved in short order a case of dementia, telling the whole story of the trajectory of these patients. Now, not all attacks are so injurious, but minor injury at least occurs in about half of patients. Yes?
కొంచెం తమ్ముడు చేత చదువుకోరాదు లేవంగానే
Uh,
1 hour అట్లా
sorry. Okay.
స్క్రీన్ ఓపెన్ చేసి
Are others hearing this voice? Okay. If you are taking phone calls or other things, please do mute. Thank you. Sorry for that distraction. And in any case, most injuries are not particularly severe. Minor injuries such as bruises, cuts, or lacerations may occur, but about 11% are serious. So that can include subdural hematomas, long bone or rib fractures, and the like. And the risk factors for injury, we found at least in retrospective study, were idiopathic or isolated RBD, so meaning they had not yet developed Parkinson's disease, dream recall, so the patients who recall their dreams, and falling from bed. We'll get into treatment later, but most frequently melatonin or clonazepam may be at least marginally effective symptomatic treatments. Great. Well, this is not the same patient, but this is an old school video that shows some of the typical, more violent behaviors that we may see in REM sleep behavior disorder. Okay. I think please mute on your end if you, otherwise we'll get some echoes through the Zoom system here. Thank you. So here we will see a video of an actual patient, not the one I presented, but one much like him. And you can see it's an old grainy video, but under the bed sheets, you'll see some fairly marked movements here shortly. You can hear him vocalizing. I hope you can hear the audio. This was a very violent early case. You can see him punching, a little profanity there, which was not customary for the patient, and a final punch. And you might have seen right at the end his eyes come open. So importantly, as these patients are asleep, their eyes are typically closed throughout the attack. So really, this is the typical trajectory of these older patients with RBD. They start with dream enactment at presentation. This is when the Lewy body disease may be at a covert stage. Otherwise, they typically don't have a lot of other problems. But as the disease progresses, you may see cognitive impairment, variable motor features of Parkinsonism, or autonomic disorders. Especially at the bedside, you can monitor for systolic blood pressure drop upon standing, so orthostatic hypotension is frequent. And then later in the course, more profound cognitive impairment with visual hallucinations preceding ultimate demise. And so you can see on these survival curves from work of Jennifer Milano in the Olmsted County database that RBD tends to present first in most patients. That's not always the case, but that is typical. Now, here's a slightly different spin on an older patient. This I'll call kind of in slang drive-by RBD for reasons you'll see. This is a 67-year-old woman this time with a history of moderately severe obstructive sleep apnea. She had just made the threshold of an apnea-hypopnea index of 15 per hour. And she was struggling mightily to adapt to CPAP. You're going to see a lot of similar patients this year, unfortunately, who struggle to use CPAP well. And she's uncomfortable with her nasal pillows. Her cat had scratched up her tubing. She didn't really have much sleep disturbance, and she had good sleep habits. Her Epworth Sleepiness Scale score was only a 4, but she had repeatedly failed to meet her Medicare CPAP requirements for these various reasons. So for this reason, had to undergo another polysomnogram for her sleep apnea so she could be treated under Medicare once again. So this was a rules and regulation polysomnogram. We were not hunting for anything other than her sleep apnea, but we found something else. During the polysomnogram, as I interpreted, and this was a patient I hadn't seen before, so I didn't have the opportunity to take a history, but I started seeing these muscle bursts during REM sleep. That one was not particularly notable, just a one-off, but as she went through the night, these muscle bursts escalated. And here you can see in submentalis, a few phasic kind of muscle bursts, they come and go. You can see some more of this activity now in the chin and the leg. You can see clear features of REM sleep, by the way, with rapid eye movements, largely mixed frequency, desynchronized EEG background with some theta rhythms and probably some sawtooth waves here. But look at all that phasic muscle activity. REM sleep should be atonic, and there's just far too much of this. Here's another epic showing similar findings. And then this really escalated toward the end of the night, and it culminated in a rather dramatic behavioral episode where the patient actually started running in bed. And you can see the behavior of this actual patient here. The video is shown here with her permission. And at first you don't see too much. She's laying quietly in bed, so much of that phasic muscle activity bursting pointed out was subclinical. She was not twitching or moving at the time, but now you see some clear running movements under the sheets. And you'll really see that start to escalate. And it looks like she's maybe moving faster and faster and running harder in her dream. And maybe now you can even hear the auditory equivalent as she's really kind of racing under the bed sheets. All lower body, which is a little unusual for REM sleep behavior disorder. And then right at the end, her eyes come open. So again, eyes closed throughout the attack. Yes. Did someone have a question? Hello?
No, we just can't see the video.
Okay. You can't hear or see the video? Hello?
Yeah, we see your screen, but it's not moving. It's not moving.
Oh, okay. Well, I'm so sorry. You missed a really good attack. I'm not a audiovisual wizard, so on the Zoom platform here, we have what we have. It played on my end, but I apologize. Okay, in any case, imagine that you saw vivid running behavior under the bed sheets, which would have been nice to see, but alas, Zoom. Okay, in any case, this is the story afterward when I saw her in the office. She recounted that she was having a running dream. She was trying to escape two men who were chasing her. She was running for the getaway car, which was in front of her in her dream. As the car pulled away, she could see the taillights and she was running faster to catch up and she was gaining on it. But alas, then she awoke before catching up with it. So this very vivid narrative would be typical of a REM sleep dream. Further history was taken at this visit because I was seeing her for the first time at this polysomnogram follow-up visit for one of my colleagues. And it revealed that for 4 to 5 years, she had had sporadic nightmares involving a chase or attack theme. Rarely she seemed to enact them. There was no bed partner in recent years, so there could have been some missed history, but she was aware of at least some of this. She had been treated with depression for a year or two before the behaviors began, following a year of major losses in her life. She lost her mother, she became divorced and had a major move from the east to the west coast. And following this, Her dream enactment escalated. She was aware of maybe 2 or 3 attacks monthly. She had had a few falls from bed and inadvertently struck her bed partner when she flailed her arms on one occasion. Further history was taken, and it revealed that she had some loss of sense of smell, some hyposmia for about a year. She denied any other symptoms, non-motor or motor of Parkinsonism, to include no constipation, orthostatism, motor or balance problems, or hallucinosis. On exam, she had a normal gait. She had good stride length and turning. She had some subtle reduction of swing of the left arm, which you'll sometimes see as a soft sign of Parkinsonism. There is no, however, hallmarks of rigidity, bradykinesia, facial masking, trouble arising from a chair, orthostatic drop, or cognitive impairment on a mental status exam. So her diagnosis would be idiopathic RBD, in this case associated with antidepressant use. So I will throw down the gauntlet here and ask for your participation. And we'll see what do people think, how prevalent is REM sleep behavior disorder? And the choices are A, 0.5 to 1%, B, 1 to 6%, C, 6 to 10%, D, 10 to 15%, or E, it depends percent. Aha, so we're getting some chat action. And let's see if I'm savvy enough to actually see that. Sally, I'm not sure if you're on the line or can tell us what the major poll reveals. We don't have polling software, I realize, but.
Actually, most of the responses are B.
Okay, most are B. Well, guys, this is a pretty smart audience. I have to say I'm impressed. Let's see here, if I can migrate off that. Okay, and are you seeing, I see now the error of my ways. I was advancing my slides on my speaker view and not on here. So this is what you should have seen for the slide. Are you now seeing that all over the internet? Okay, well, here's the answer, okay? And you can see it's a little equivocal, as are many things in neurology. The right answer by evidence in a population basis is probably B currently. We've just had some epidemiologic studies in the last few years that have solidified this a little bit. In fact, you could really say maybe even leaning towards A. But I'm going to also suggest that E was okay. It depends percent. It depends on which population you're looking in, if it's a sleep clinic, which is enriched, or a general population-based study, which would be proper for epidemiologic prevalence. But let's just review that briefly. And idiopathic or isolated REM sleep behavior disorder. So by the way, those terms are synonymous, and within the year, some of our colleagues have begun using this term isolated, which means really idiopathic doesn't seem so appropriate anymore when you presume that this is a degenerative disease underlying it as the etiology. But in any case, early surveys had suggested even less RBD out there. Dr. Ohayan from Stanford had done a telephone survey of violent sleep behaviors years back that suggested about a 0.5% prevalence. But more recently, independent population-based studies from Switzerland and Korea with polysomnography have revealed somewhere around a 1 to 2% prevalence in the general population as being most likely. Some years ago, though, in enriched populations, Birgit Frauscher had published a paper looking at sleep clinics, suggesting a nearly 5% prevalence there. So 1 out of 20 of your patients might have REM sleep behavior disorder if you are asking the question consistently. And importantly, work from Barcelona revealed recently that almost half, 43%, may present with RBD as a secondary or incidental sleep complaint, just like the patient that we found looking for sleep apnea in the laboratory. If you look at older adults also, it looks like this population is enriched, unsurprisingly, because Lewy body disease prevalence is higher in the elderly. And if we look in that group, this is mostly from survey-based studies, which may slightly overestimate the prevalence, but they're finding more numbers like 5 to 8%. And one study in Sun City, Arizona even suggested 13% prevalence for RBD symptoms, at least. So that's for idiopathic or isolated RBD where there's no Parkinsonism, at least yet. Now, in symptomatic RBD, this term means that they've developed some other neurological disease or disorder, usually a Lewy body disorder or a synucleiopathy. And in various synucleinopathies, Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy, you can see the prevalence range is somewhat wide, but particularly frequent in those with dementia with Lewy bodies, where one study suggested about an 80 to 85% frequency, or multiple system atrophy. A recent meta-analysis suggested nearly 90% of patients had it. On Parkinson's disease, it's a little more heterogeneous, and probably between a third and half of patients have REM sleep behavior disorder in that patient population. Now, a really good screening tool, this will sound biased, of course, coming from the Mayo Clinic, but the Mayo Sleep Questionnaire has been heavily validated. One much like it developed by Ron Postuma and the RBD study group called the RBD1Q, which is nearly the same thing, asks this question: have you ever seen the patient appear to act out his or her dreams while sleeping, i.e. punched or flailed arms in the air, shouted or screamed? Now, validated against polysomnography, asked to the bed partner, the sensitivity is quite high, nearly 100%. The specificity somewhat lesser, but in certain populations and with enriched additional questions, it gets to be pretty close. So this core question can be very good for screening, both in epidemiologic studies, but also in the clinics. Now, timely diagnosis of this disorder, REM sleep behavior disorder, is crucial for at least two reasons. The two practical reasons that it would be important to define it for include its injury potential. As we saw in our first patient, about 10% or so may have serious injury. So it's important to offer symptomatic treatment and advice on bedroom safety to prevent that. On the other hand, the prognostic implications are huge. And patients, we might argue, deserve to know what's coming, or if they want to know, that is. That's a bit of an ethical conundrum. You know, how do you tell the patient for an unactionable condition that they may be developing a neurodegenerative disease? That's a tough one. But nonetheless, the prognostic significance, as you'll see soon, is very significant. Now, what about the differential diagnosis? Well, there are several mimics of REM sleep behavior disorder that may present with complex vocal motor behavior during sleep as nocturnal events. At the top of the list, as sleep clinicians, we have to think of so-called pseudo-RBD. And this tends to be a case of sleep apnea that's gone undiagnosed with motor behavior arousals. And often they'll have these not only from REM sleep, but from non-REM sleep. So polysomnography is necessary not only to confirm the presence of REM sleep without atonia, but also to exclude the presence of comorbid obstructive sleep apnea. And in fact, what we found is comorbid sleep apnea is quite prevalent anyway, unsurprisingly, in these elderly adults. So how do you tell the difference? Well, if you treat the apnea and the attacks continue, it's very likely REM sleep behavior disorder. And that, in fact, turns out to be the case most of the time in North America. There's also the non-REM parasomnias. Now, importantly, these are disorders of arousal, chiefly in non-REM sleep and rarely out of REM sleep also. But the patient wakes up with a normal spontaneous arousal, but they're behaviorally confused and they're in a bit of a twilight state, trapped between outright wakefulness and partial sleep. So they're capable of complex motor behaviors, including sleepwalking. So oftentimes it's a clue if there's prominent sleepwalking in the patient, that could be REM sleep behavior disorder still, but usually implies the presence of non-REM parasomnia. And usually the patient there may not have a vivid narrative dream enactment. While it can be hard to distinguish, most older adults do not develop de novo non-REM parasomnia. Many times you'll hear the history of having parasomnia since childhood or a strong family history of sleepwalking, sleep terrors, and related non-REM events. There's also nocturnal or sleep-related epilepsies as a mimic. Usually this is differentiatable from REM sleep behavior disorder by its stereotypy. So patients with nocturnal and sleep-related epilepsies, frequently one attack is the same or very similar behavior as to the next. And most of these episodes that patients have tend to be stereotyped as a distinguishing point. Well, great. Let's, at this point, move on to discuss some of the evidence cementing this idea that in most older adults, idiopathic or isolated RBD is a prodromal synucleinopathy. And what starts as RBD here in the middle, most often will, over a time course of years, usually 10 to 12 or 15 years, evolve to one of these other major syndromes, a cognitive, motor, or autonomic syndrome with the named phenotypes of Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy. There are a few other spectrum disorders in that, such as pure autonomic failure. I'm not going to go down the wormhole today to define all of these from a neurologic perspective. But conceptually, I think the important thing to realize is that patients tend to evolve in one of these trajectories, and the progression is variable. And so realize when you identify the patient, you're going to identify them not always right in the center with totally isolated or idiopathic RBD, but conceptually there may be somewhere along their trajectory. So you're going to see some soft signs, often measurable at the bedside, that can help you appreciate the likelihood of an underlying Lewy body process. Now, when one looks at longitudinal cohort studies, largely assembled from sleep and movement disorders centers, patients with REM sleep behavior disorder, about 75 to 90% of the time, meet Neurologic Movement Disorders Society criteria to have prodromal Parkinson's disease. So that's one line of evidence that this is what it is. There are also frequent findings of neurodegenerative markers in living patients. Frequently, these are non-motor signs, things like hyposmia, constipation, bedside autonomic nervous system impairment with orthostatic hypotension. There's also been evidence published in recent years of pathologic specimens from peripheral tissues showing alpha-synuclein pathology in various tissues, including the salivary glands, the skin, the GI mucosa, and the gonad tissue. So this does look like a systemic disorder, and there is evidence in living patients in vivo that they have synuclein already in their body outside the brain. Then there's evidence from autopsy postmortem studies that about 94% of patients have synucleinopathy who have had RBD in life. So let's throw down the gauntlet again. We'll ask for another straw poll. And what is the approximate percentage of idiopathic or isolated RBD patients who ultimately will phenoconvert to a synucleinopathy over longitudinal follow-up? And here we're talking a time course of 10, 15, 20 years. What would people think? And Sally, I'll ask you to be our poll taker here. And what are people saying to that?
We received a D and an A.
A D and an A. Okay. Okay.
And
Well, that's and a B. Okay.
Actually, people are responding now. I'm sorry.
Okay. Okay. Sorry, I should have had some polling software organized for this. That would have made this easier on your eyes.
It looks like we're getting mostly D's, but there are A's, B's, and C's and E's.
So it's a little heterogeneous, and it's a bit of an unfair question if you're not either a neurologist or been following this field. But it turns out D is probably the best answer. That could be a bit controversial. It depends on perhaps what center you're at and which studies you've read. There's some evidence for C and E as well, but A and B are, as they said on Monty Python, right out. Okay, but if it turns out if you follow these people long enough and look at a Kaplan-Meier survival analysis, these patients convert at an annualized rate of about 6% per year. Some studies from Montreal suggesting more like 7 or 8%. But then if you look at the cumulative risk over time and do the math, basically by 10 or 12 years, you're out to 60 to 75%. And probably the best study of this type, recently done by Ron Posthuma, who organized it, and featuring all of our 24 worldwide idiopathic RBD study group centers. So this is pooled data from about 1,200 patients, 1,280 to be exact, showed that the cumulative risk at 12 years is about 75%, 73.5. So it's high. Now, if you look at various non-motor and motor features that we call neurodegenerative markers, largely done for research, but if you're a neurologist and like to geek out about this stuff, you can either ask the questions at the bedside or measure some of these things with validated tests. Abnormal olfaction on a scratch and smell test is about a 2.5 to 3-fold hazard ratio for development of future dementia or Parkinson's disease. If we look at abnormal motor testing, broadly defined, either motor symptoms or signs, that's an enrichment factor. Constipation is a little bit less because it's a little less specific probably. Increased RISWA on the polysomnogram also emerged as one, a little more borderline, but when you think of it, it's kind of impressive RISWA emerged at all because everyone has it. So there's really kind of a ceiling effect there with RISWA. And then an abnormal DAT scan, which I'll show you shortly, a dopamine transporter uptake scan, is one of the most enriched factors to suggest that they have loss of dopamine signaling in the brain already measured in vivo. And that is a pretty serious risk factor for developing Parkinsonism or dementia. I also alluded to autopsy evidence, and my colleague Brad Beauvais here at Mayo assembled a worldwide consortium of postmortem exams and showed that 94% of patients at post showed evidence for synucleiopathy. So not all, but nearly all. There have been precious few idiopathic or isolated RBD cases published with pathology who died at the state of idiopathic RBD. Of two that I'm aware of, there was a 15 to 20 year history where no other obvious pathology was present, and both patients showed Lewy body pathology in the brainstem at about the level of the REM sleep Atonia control and REM sleep control system. The sublateral dorsal nucleus, if you're a rat, in humans we call it subceruleus, and or the pedunculopontine nuclei. So also there's living specimens from living patients that show patient pathology in various tissues, as I alluded to, the submandibular gland, the GI mucosa, the gonads, and the skin. So you can find phosphorylated alpha-synuclein deposits in these patients with evidence for synucleinopathy. This is the DAT or dopamine transporter uptake scan I alluded to. Here you can see a healthy intact dopamine system with double comma sign, both basal ganglia lighting up nicely. And here you see variable signal loss in cases of RBD. And if you see one of these, that's a bad sign for short-term evolution of a Parkinsonism or dementia phenotype. Well, now let's move a little bit to the idea of REM sleep without atonia. This is the neurophysiologic signature of RBD. On the bottom of this screen, you see normal REM atonia. We see features of REM sleep with rapid eye movements, desynchronized mixed frequency EEG, and atonic EMG background. Flat as a pancake, maybe a few little tiny bursts, but nothing substantial. By contrast, this patient with RBD, not much in the chin, but you can see in the limb leads here, the individual right and left leg, right and left arm, all kinds of bursting phasic muscle activity that's abnormal. Now, you can measure this stuff. I will not bore you with the details. There are different methods for doing this. There is an AASM method, which is quite close to ours, and the SINBAR method. But basically, the types of activity to be familiar with include phasic muscle activity, which is what we saw in the last figure. These are transient bursts of brief duration. There's tonic muscle activity, which is an increase in the whole background voltage amplitude. And then there's the term any, which is really a collapse term, meaning either phasic, tonic, or both. What is typically done is dividing up the 30-second epoch into 10 3-second mini epochs, counting the phasic muscle activity bursts as they occur as a positively scored epoch, and then doing simple division, just as you would with the apnea-hypopnea index. You divide the positively scored muscle activity burst epochs over total REM sleep mini epochs, and this yields a metric of abnormal muscle activity. And when you do this, you find significant separation. You do find that controls have some of this activity, okay? Probably not over about 20% of the background. And then we see in patients, they tend to have a lot of it. This shows a little bit more operationally, getting into the weeds here, how if you're scoring this activity, this would be a positive mini epoch because there's a bunch of little bursts. Here's another one and another one. In fact, all of these 5 mini epochs are positive for phasic muscle activity, but each one looks a little different, right? And so we've actually in our lab said, well, maybe we can be a bit more precise and try to directly score the phasic muscle activity bursts. And that's another method you can play with in this. Now, this 90-second epoch is showing tonic muscle activity in the middle. The 2 surrounds have no tonic muscle activity. And then you can see some phasic muscle activity bursts, phasic over the tonic, and then some phasic muscle activity bursts in the leg. And what this is all trying to show is tonic muscle activity must be at least 15 seconds in duration in a 30-second epoch to score it. And while we see a little tonic here, perhaps it doesn't rise to that 15-second threshold. The other thing you can see here is that neither this or this epoch have 5 or more mini epochs positive. Sorry, I had that wrong. This one has 5, this one has 5. So the blue cross here means this would be a positive AASM method, which requires you have 5 mini epochs positive for the presence of RISWA before you score it. So there are some different methods to this. Probably for your training program or exams, I would know the AASM method. Now, importantly, I'll mention when looking at RISWA, you have to exclude physiologic sources of increased muscle activity. And this is one of those. This is an arousal from a sleep apnea episode from a respiratory effort-related arousal. And you can see that the muscle activity comes up during REM by definition to score it as an arousal. So when you're actually considering RISWA, you have to make sure you're thinking about, is it really a physiologic event with increased muscle activity, which doesn't count, or is it in fact REM sleep without atonia? And sometimes making that distinction can be tricky. Well, currently, I'm sorry to tell you, there are no well-accepted standards for how much muscle activity is too much. It's still a bit of an eye of the beholder as to whether you call it REM sleep without atonia or not. Current studies are actually lowering the threshold and finding that basically we've probably set the bar too high with case control studies in the past. But if you wanted to remember a few numbers, you could remember one number from our study suggesting about 1/3 to up to half if you're looking at the combined submentalis and anterior tibialis. For the submentalis alone, probably over 20% is abnormal. And if you're using the SynBar European method, about 30%, somewhere between 25 and 30% of the combined submentalis and bilateral flexor digitorum superficialis, which is our muscles. And there are automated methods that I won't get into at this point, but I think the future has to go there because scoring this stuff is very time intensive and tedious. Now, why would you ever bother to score it? Well, in addition to having a nice quantitative metric, which is sometimes nice to hang your hat on in subtle cases, there has been on a research front all kinds of evidence suggesting that REM sleep without atonia also associates with synucleiopathy. That includes distinguishing synuclein from tau pathology in elder patients. It suggests that REM sleep without atonia may be a marker for prediction of phenoconversion from idiopathic RBD to Parkinson's disease. There has been evidence that it associates with Parkinsonian phenotypes that are more severe, and that tonic muscle activity may associate with the really significant feature of gait freezing in Parkinson's disease. Now, as just one illustration of this, this is data from our lab pooled across a couple of papers. So this is not a stolen figure from an article, but a combined data set of 140 patients nearly, showing that in the submentalis, the amount of REM sleep muscle activity distinguishes dementia with Lewy bodies, multiple system atrophy, Parkinson's disease, from other common neurodegenerative disorders of the elderly: Alzheimer's disease, cortical basal syndrome, controls with sleep apnea, frontotemporal dementia, progressive supranuclear palsy, to name a few. So the presence of this stuff really does suggest a synucleinopathy. The leg is a little noisier, as you can see, but the chin really distinguishes these well. This is another figure from one of our published works, not a published figure, just to make that clear, that when you draw survival curves stratifying on the amount of muscle activity combined across the chin and the leg, you can find a threshold of about 45, 46% combined with age that really suggests a poorer prognosis for progression to Parkinson's disease. And then I alluded to this fact that there's REM sleep without atonia in normals, and I'll just reference our recent paper on this, which was one of the very first normative studies in a sleep population without RBD. And it turns out REM sleep without atonia is, depending on how you define it, is pretty common in patients without RBD. It's more common in older men, especially, and there is some evidence that we can begin to now take the timeline back and find REM sleep without atonia before there's REM sleep behavior disorder. Now, there's been another study also in Innsbruck, Austria, of normative levels of REM sleep without atonia, and they found about the same thing. About 25% of their elderly had REM sleep without atonia that met RBD thresholds. So it's not uncommon. If you follow these patients over time, there's been precious little outcome evidence yet of what that means, but 7 to 14% actually developed RBD. It turns out, if you read this paper carefully, 2 of their patients developed RBD over time. About 70% had the abnormal neurodegenerative markers, so they look a lot like they have RBD already. And this is a group, I think, that remains a frontier, but of keen research interest. Well, what about the other causes in our remaining time? I do want to get to beyond synucleinopathy. And I think the story is pretty well writ that over age 50, 55, or 60, most of this is going to prove over time to be a Lewy body disorder. But in younger patients, there's far less certainty to this. There's a more even gender split, more women with RBD in younger patient populations. There are more patients and more overlap with psychiatric disease and antidepressant use. And there are additional causes of narcolepsy, structural or lesional pathology, and even autoimmunity. So we'll throw down the gauntlet with one more pollster question. Do RBD patients receiving antidepressants have a different prognosis than those who are off of antidepressants at presentation in terms of their risk of evolving a synucleinopathy? And the choices are A, B, yes, no, C, maybe, D, I don't know, and E, I don't care. I hope we don't have any E's, but let's see what people think here. Sally, maybe you can, again, do a rough straw poll for us and see what the audience thinks. And survey says?
People are still responding. Give them another few seconds if you don't mind.
Sure.
Looks like B.
It looks like E? Uh-oh.
No, B is a boy.
B as in boy? Okay. Okay, well, that's, again, a very informed audience. I'm impressed by you guys and gals. All right, so I think the answer probably is B, but it depends. Again, I'm going to qualify that and hedge a bit because it could be C in young patients. We need more evidence in the younger patients about what their trajectory really is. But this key paper from the Montreal group, and again, Ron Posthuma's great work, suggests that whether you're taking an antidepressant or not, there is still progression to synucleinopathy. There's been various interpretations of this data, including that maybe antidepressants are neuroprotective. But another explanation could be that this reflects lead time bias and that antidepressants are doing something to unveil the disease earlier, so then you would see a survival advantage for those patients. They would not progress as quickly as those who are off antidepressants. So still theoretical at this point. We need more longitudinal outcome studies. But if you looked at the neurodegenerative markers again, whether it be olfaction, color vision loss, a motor tap task, or systolic blood pressure decrements, you can see that the RBD patients on or off antidepressants have overlapping results here, all distinguishable from control. So it suggests these patients do have soft findings of a Lewy body disease. If you look at just the REM sleep without atonia, it is interesting that one finds comparable levels of REM sleep without atonia in those with traditional RBD off antidepressants, or what we called psychiatric RBD in our population, which meant you were on an antidepressant when you developed your RBD. And then there's psychiatric treatment, which meant no RBD, but you can see intermediate levels of RISWA. So the antidepressants are doing something to the atonia control system that elevates RISWA. And you can see untreated patients with psychiatric disease or controls off antidepressants really show comparable results there. All right. Well, I alluded to this. There's not that much evidence yet about RBD in narcolepsy. So this remains another frontier, but as a boundary state disorder, narcolepsy does cause parasomnia and RBD in a significant minority, maybe 15 to 35% of patients. It can be a presenting manifestation, especially in children, and it's been linked mostly with type 1 or hypocretin deficient narcolepsy as versus type 2. If we look at the association with autoimmunity, it can be associated with REM sleep behavior disorder in younger patients. Most of these younger patients will have a syndromic presentation. And by that, I mean they not only have the RBD, but they have other stuff. They have prominent neurologic disorders or sleep symptoms, including insomnia and hypersomnia in addition to their parasomnia. A prototype is Morvan syndrome, where they have peripheral nerve excitability, insomnia, and sometimes seizures, and there's overlap with limbic encephalitis here. These have been linked particularly to something known as the voltage-gated potassium channel complex, or in the current vernacular, the LGI1 and Caspr2 targets. So consider evaluation for autoimmune encephalopathy in these patients who have a subacute syndromic presentation. Another one called the Iglon-5 syndrome has been recently described, and this is a really bad actor that may have tau pathology, interestingly, in postmortem, and which doesn't seem to respond well to treatment, unfortunately. But in other populations, particularly the VJKC, LGI1 and Caspr2 patients, immunotherapy is directed by an autoimmune neurologist can really help improve their situation. And then last, lesional RBD. This is data from our recent book chapter in the textbook of RBD, written with Stu McCarter, but we did a mini meta-analysis of the existing case reports at the time. We found 44 of these, and they had similar features to those overall with idiopathic or isolated RBD. Older men, in particular, were the predominant patients. So a question could be, is this tandem pathology? Is the lesion even an epiphenomena? But a variety of etiologies were found: vascular, inflammatory, autoimmune, or tumor. And the location was really more determinant of RBD than the nature of the lesional pathology. Now, here's one case that we had reported. Again, not the image from the article, just to make clear I'm not violating copyrights here, but you can see this little blush of pathology in the dorsal lateral pons. It's a little shifted more towards the right side. And in fact, this is right about where nucleus subceruleus and the REM atonia control system would be. So the idea is a lesion of that center causes loss of REM sleep without atonia and the other cardinal manifestations of RBD. Well, what about treatment? I want to say that the most important form of treatment is bedroom safety counseling. You want to counsel the patient to keep their bedroom safe and secure, to remove any weapons or samurai swords over the bed from the bedroom seam, to apply cushions to the floor near the bed so if they fell, they wouldn't be injured, moving away sharp-cornered furniture. Mike Howell, our colleague at Minnesota, described a POSI bed alarm system that can be helpful, particularly for patients who sleepwalk. In terms of treatment, there remains precious little evidence, mostly from poor grade evidence retrospective survey or retrospective case series descriptions. Clonazepam has been the drug of choice. It is a modulatory to the GABAergic neurochemistry of the nervous system, probably thereby inhibiting REM sleep without atonia to some degree, although when you look at the data, it doesn't seem to have an effect that way. Melatonin might have even a little better effect that way, at least in preclinical models. There have been a variety of other medications described in small case series, but suffice it to say the evidence remains poor. If you're using clonazepam, the dose range is about 0.25 to 1 or 2 milligrams at the top end, with melatonin 3 to 12 milligrams, with 6 milligrams being the average effective dose, is what we've found to be effective. We do hope that as we understand the natural history of this disorder better, that we will have neuroprotective treatments. I wanted to give a shout out for our NAPS consortium, the North American Prodromal Synucleiopathy Consortium. The website is shown there. There are now 10 North American centers enrolling patients. This is an older slide, so we now have over a couple hundred patients enrolled. And hopefully, if NAPS 2 is funded, this will be an ongoing effort. But in any case, this is a natural history clinical trial planning study. So we're hoping to have a good enough understanding which patients are vulnerable to progress to administer a neuroprotective therapy eventually to these patients. So in conclusion, RBD is common, it's injurious. It's diagnosed when there is dream enactment and REM sleep without atonia as its cardinal features, and one may treat symptomatically with melatonin or clonazepam. Hopefully I've convinced you that the prodromal synucleinopathy theory is most compelling in older adults, even when they're using antidepressants. So all patients require neurological surveillance and longitudinal follow-up. And REM sleep without atonia also occurs independent of RBD, and one should think of additional etiologies of narcolepsy, antidepressants, or autoimmunity, or brain lesions in younger patients. So a brief word of acknowledgement to my laboratory colleagues, my mentors and funding sources, and to my colleagues here at Mayo Clinic who are hard at work in the trenches right now, so I can share this time with you today. So thank you to all of them, and thanks for your attention. I think we have a few minutes remaining here for questions, not as much time as I hoped. So, but please ask any questions that you may have. Feel free to unmute yourself, and we can have a few minutes of dialogue if your time provides. Or perhaps I've bored you into submission, and if that's the case, that's okay too. Wow, stunned silence, crickets. Don't be shy. You're making an old man feel really bad.
Thank you for the excellent presentation.
Not so bad, I'm kidding. Of course, that's the two interpretations. Either is I've put you all asleep, or it was so crystal clear there are no questions. So I'm hoping for the latter.
You did receive one question.
Good.
How do you balance risks and benefits of clonazepam in elderly with RBD?
Great question. There remains no true evidence basis for distinguishing their use. Our bias at Mayo Clinic has been pretty strong towards melatonin. And I'll reference you to our treatment outcome study from a few years ago. It does look like both drugs are equally effective, or perhaps equally ineffective. One of my old mentors would call it jokingly the trial of two placebos. So I think we're in need of better evidence basis, but in the elderly, my bias is to start melatonin because it's safer and better tolerated. And available evidence suggests these two work about the same. So we usually lead with melatonin, try that first, get them up to 6 milligrams, hold there. Rarely does that stop the behaviors. So oftentimes they'll keep having attacks. If they have anything that sounds bigger or more injurious, I may ramp up the dose further or then switch to clonazepam. And I'll mention we have a lot of patients who end up on both treatments.
If melatonin and clonazepam, either singly or in combination, does not work, off your list or off your own experience, what's the next step you take?
Oh, you went right for the throat, man. So I would say that, then I tend to see, is there a strategic comorbidity I can treat? So if it's an idiopathic isolated patient with cognitive impairment, I'm probably going to go more towards donepezil or rivastigmine, something that is an anticholinesterase medication to offer some cross-efficacy for cognitive symptoms. Whereas if they may have soft motor impairment, I may go pramipexole, actually, to try to offer some dopaminergic motor benefit. And I know some of my colleagues, particularly maybe in Spain, who tend to think pramipexole doesn't work, may shoot me for saying it. But I would say that either can also selectively add some benefit, and you're probably actually treating their comorbid soft sign more than you're treating the RBD itself.
Got it.
There's another question. Could you please explain your scoring method for RISWA again?
Okay. Oh, wow. Yeah. So in the remaining 30 seconds, I'll just say very quickly, the Mayo method is quite similar to the Montreal method. The grandfather of them all, Jacques Montplaisir, wrote the first paper on how to do this in 1991, I think, published in Neurology, Lapierre and Montplaisir. So look that one up. The rest of us have just actually copied that, whether it's the SynBar group, our group, we've all put our own spin on it. But the Mayo method's a little different in that we allow a longer phasic burst. So there are duration and amplitude criteria for scoring phasic muscle activity. And we will call that window from 100 milliseconds, 0.1 second, all the way to 14.9 seconds. Whereas the SynBar and Montplaisir groups cut it at 5 seconds. Why did we do that? Why the difference? We were interested in trying to quantify the duration of this muscle activity, and to really show, does that add additional discriminative value for diagnosis of RBD and or for prognosis? And I'll invite you to look at any of our papers. There's a soft sign that from that work that actually doing the phasic burst duration measurement, which is quite tedious and time consuming, but if you do it, it may improve the diagnostic value slightly. More importantly, it might become a shorthand approach. And what we're finding is that patients with disease have longer bursts, probably more like a second in duration or longer quite often, or at least over half a second. So if you see really short bursts, you even might wonder, is it abnormal activity? There's another phenomenon known as excessive fragmentary myoclonus. This is activity that is supposed to be no longer than 150 milliseconds, but in real life sometimes is. So, and everybody has a little bit of that. So we think measuring the burst duration is impactful just to make sure it's disease and maybe to help discriminate the diagnosis a little better.
So thank you for explaining that. Quick question for the AASM criteria for scoring RISWA.
Yeah.
Is there a minimum duration of REM sleep that should be achieved to be able to apply?
Great
those
question.
criteria?
Very good question. No one has really standardized this. So we actually went with the SynBar suggestion, and our colleagues there at SynBar, great work from Spain and Barcelona and Innsbruck, Austria. But in their approach, they suggested a minimal 5-minute duration for REM, and we adopted that, at least in our research papers. I will tell you, sometimes you don't get 5 minutes of REM, and there you may rely more on qualitative methods and really the old eyeball and human visual system to sort of say, with an experienced eye, is it or is it not RISWA? But I have less confidence when there's not as much sampling, or particularly when there's severe REM-related sleep apnea without a CPAP trial. So that is a whole nother conundrum. If you don't have enough artifact-free REM, then it can be really hard to judge.
Great. And one last question. So in our lab, we use that more than 50% of the total REM epochs should have the excessive twitching for us to say it meets the PSG criteria for REM sleep. Is that reasonable?
I'm going to answer that in a qualified manner to say one problem with the AASM approach is they threw out there that a single 30-second epoch, the You know, they didn't actually give a cutoff of how many abnormal epochs there should be. You know, so is one enough? Probably not. You know, I think that's a pretty low bar. And that's why, you know, I think our group, Montreal and SynBar, have not gone, you know, where did the AASM come up with that? As far as I can tell, they picked it out of the air. There's actually no empirical evidence to support that as a defining feature of RISWA. So you might tell my bias, I don't think it's a very good standard. Still in our published papers, we've done it because it's out there and felt that there should be some norms developed. So, you know, there are cutoffs for that. And I reference, you know, either the pivotal SynBar paper, Frauscher 2012, or our paper, McCarter 2014, where you'll find some actual cutoffs for what that, you know, how many epochs might be too many.
2 final questions, if you don't mind.
Yeah, absolutely. Happy to stay on.
Is there evidence that narcolepsy patients may progress to RBD?
Ooh, wow. Now someone really went for the throat. I think that is really a frontier, you know, frankly. We just don't really have any good evidence on that at all. I believe there's a recently published case from Posthuma in Montreal to suggest in a single case, a patient who progressed from narcolepsy to later, I think it was DLB, could have been Parkinson's disease. And I can tell you anecdotally, we have a very small kindred here at our center that we're following with great interest because they seem to have early life narcolepsy type 1, and now in late life seem to have cognitive impairment and signs of dementia. So I think the jury is out on that one, and we need, you know, better prospective research studies. When you're counseling patients, I usually counsel them the other way, frankly. So we have no evidence that in narcolepsy, RBD holds the same prognostic significance as it does when it evolves idiopathic isolated in older life.
Okay. And the final question, do you use a specific brand of melatonin?
Okay, another good one. The answer is not really, although I think here in North America, as you might be aware, at least in US, it is a non-FDA regulated, over-the-counter substance. So it's pretty heterogeneous what's out there. You know, studies that have actually compared melatonin formulations are a little concerning that levels of melatonin in various preps are kind of all over the place. I own no stock and have no consulting relationship, but I will tell you lately, I have seen evidence from the product known as REM Fresh. So it does appear to be pure melatonin, and there is some studies with it in insomnia that at least hold some promise there. To date, there have been no studies in REM sleep behavior disorder, but I do mention this point to patients. Obviously, they can buy whatever they like. But REM Fresh is one proprietary form of melatonin in North America that may be superior. It has a more controlled release profile as well. Now, in Europe, there is a regulated form called Circadin, available in a 2 milligram dose. I believe they also have it in Australia. And disappointingly, with that and a randomized controlled trial at low doses, at 2 or 4 milligrams of melatonin, it looks like there really is no efficacy, at least in Parkinson's disease RBD versus placebo. So I think we need further evidence basis for sure for symptomatic trials. I'm hopeful that in the next 5 years, there will be some better evidence as to whether these things actually work or not.
And one additional question, have you seen whether certain types of SSRI or NSRI lead to more RBD?
Great question. Yeah, so there remains little evidence about differential impact of antidepressants on REM sleep without atonia or RBD. By legend, and largely this is from our colleague Carlos Schenk, who initially described the disease in the mid-1980s along with Mark Mahawald at Hennepin County in Minnesota. But Carlos and others have alluded to the fact, and I have some anecdotal success, sometimes a switch to bupropion or Wellbutrin, a dopaminergic antidepressant, may be helpful. There is evidence in restless leg syndrome that can be helpful. And anecdotally, I think sometimes in RBD it can be helpful. I don't do a lot of switching in these patients unless there's a clear temporal association between the onset of RBD symptoms and the start or dose change of an antidepressant. Lacking that, I tend to leave their antidepressants alone. Anecdotally, I would say the SSRIs and possibly SNRIs are probably a little more provocative for REM sleep without atonia, but we're actually doing a big study to look at that right now and try to discriminate, which antidepressant does how much damage. And I think it's still a bit of an open question.
One additional question.
Yeah.
Do you counsel patients who have RBD that are over age 50 to follow up with neurology and tell them they have a high chance of development of
Yeah, this is a delicate issue, and I think there's no good consensus yet how to counsel the patient. I do think they should be told generally that there is a risk, generally a pretty high risk. And then if they want to know numbers, I'll get into the weeds with them and give them more specifics. So I think it starts with that kind of shared decision-making paradigm. Ask the patient how much they want to know. It probably is better coming from the doctor than them discovering on Dr. Google or getting misinformation from the internet about this strong connection. My practice is to counsel them that there is an association. And then importantly, since I am a neurologist, I follow these patients as long as they're willing to come back. And now video telehealth has become another nice way to do that. We have a large RBD research registry here at Mayo Clinic, so we try to enroll them in that so that we have enriched measures for follow-up. But we try to follow them all as long as they're willing, with the idea that they need a cognitive and motor assessment, at least on an annual basis, to see if they might be converting. And largely right now, absent a neuroprotective or actionable strategy, that is for the purposes of prognosis. But ultimately, we hope that these become potential candidates for neuroprotective therapy.
Okay, I guess that's all we have. Thank you.
Well, thank you very much. I'm delighted to have had the opportunity to meet with you. Thanks for your engagement, and really happy to have had the chance to spend this time with you today.
Thank you all for attending. Thank you, Dr. Satin.
Thank you very much. I'll mention too, as you leave, if you have questions later, feel free to email me. It's both in the chat and on the final slide. Take care, everybody. Stay well.